Hey, good morning. This is Dr. Nick Tulo here with the Saturday morning clinical live stream. Thank you so much for tuning in. It looks like we have 9 people watching. So that's really cool, and I'm really happy that you guys are interested in heart rhythm problems and reading ECGs and arrhythmias and the clinical aspect of my job. I'm a cardiac electrophysiologist. I practice in New Jersey. And I had a bad day yesterday, boy. We had a lot of patients. We had 13 new patients on the service. Plus I had 3 procedures, including a pacemaker and an ablation for atrial flutter. So it was a crazy busy, like 11-hour day. But I really enjoy what I do. I just love being an expert in cardiac arrhythmias. And I hope that these Saturday morning clinical live streams give you an idea of how someone in my position thinks and give you a better idea of how to approach unknown ECGs and how to really become an expert in reading these. Of course, if you enjoy this content, please subscribe using the button down below in the description and share it with your friends. Let them know that I'm going to try to do this every week. Still struggling with a big renovation project in the house. But I dug out a new room in the basement, which is going to be my new recording studio. So maybe in about a month or so that'll be ready. And I promise the video quality will be a little bit better, but it's still going to be me. So I hope you enjoy it. Anyway, let's get to the case here. And, I always talk about Tulo's law, right? Anything that you read on a rhythm strip, don't believe anything you read on a rhythm strip unless you wrote it yourself. And that's the problem. I open up charts and I see things that that were posted by the nurses or the telemetry techs, and sometimes it either it's just wrong, but a lot of times what they'll do is they'll see something and they're not really sure about it. And I'm going to show you a strip that was labeled wide QRS tachycardia, which is a great description of what the cardiogram looks like, but it doesn't tell you what it is, really. So please avoid using vague, kind of non-committal terms. If you're not really sure of what it is, what I hope to do is be able to provide you with the tools that boost your confidence, since I think if you just rely on pattern recognition, it's, half the time you're going to be wrong because things don't always look like what they are. Right? You look in a textbook and you look at what VTAC looks like, and if you only rely on pattern recognition, if you just say, oh, well, that looks like the textbook, sometimes you're not going to be correct. And I want you to be confident in your position. If you're in the healthcare industry, number one, you're taking care of patients, and it's important that you get it right because, after all, patients are relying on you to treat them properly. But more importantly, like if you're a telemetry tech or if you're a nurse, you're signing your name and you want the doctor to come by and say, yes, that's right. You got it right on the money. You want to have the confidence and you want to be, feel like you know what you're talking about. Unfortunately, there are a lot of people who are in a position where they're attempting to read these things and they're not really sure, and sometimes I have to ask their friend, hey, what do you think this is? Take a look at this and see. But what I'm trying to do is give you the tools to be able to be confident. Be sure. Yeah, all right, so let's look at the first strip here. And okay, let me give you the case presentation. This was a 68-year-old woman with no prior history of any heart disease. She's followed by her internist. She had an echocardiogram not that long ago with normal left ventricular function, normal everything. And she comes in with a GI bleed, and she had some diverticulitis, but they put her on telemetry after she had her colonoscopy, and in fact, she was sort of dozing, and we had this tracing right here. So this actually was posted in the chart and was labeled wide QRS tachycardia because that's what it is, right? But let's try to be a little bit more precise and try to figure out what it is. Now, last time, the last chalk talk I did, was a wide QRS tachycardia. And I made the point that if you just look at the middle of it, it's very hard to tell exactly what it is. That 90% of the diagnosis is going to be in the beginning, how it starts, and in the end, or how it ends. Because you have to try to figure out whether it's originating from the atrium or the ventricle, and the first beat of the tachycardia is very important. But when we look at this tracing, we can see along the left-hand part of it is that you have a regular rhythm here at a rate of about 70 beats a minute, and there's a PQRST, so it certainly looks like a normal sinus rhythm. And then you have this crazy, weird, this whole series of FLBs, right? You know what FLB stands for, right? Funny looking beat, right? So we have to try to figure this out. I was just looking at the comments. Ricardo Vianello is back again. Thank you so much. Tech Slacker. Is it broad complex tachycardia? It is a wide complex tachycardia, but that's the whole point of this, is that it's not good enough to call it that. That's like saying it's a car. It's not a truck, it's a car. But what kind of car is it? So you really want to try to figure out whether this is ventricular in origin, whether it's VTAC or something like that, or whether it's an atrial arrhythmia that conducts aberrantly. I mean, that's the whole point. So, so how do you figure that out? Well, I always say, okay, so let's try to get to the physiology a little bit. Remember the cardiac conduction system. Let me draw on this layer. So you have your atria and your ventricles. This is my John Nagy heart. It's a little little nasty today, but it's Saturday morning. So your sinus node and your AV node, and the AV node is connected to the bundle of His, and you have your right bundle and your left bundle branches. Okay, so we have to remember the physiology, though, is that the interventricular conduction system, the His bundle, the bundle branches, and the myocardium, those cells fire because of rapid sodium that rushes into the cell during the action potential. So you have, during phase 0, you have sodium rushing into the cells to make the cells more positive. So you have sodium rushing in, and then at the end of the action potential, potassium rushes out of the cells, and that restores the resting membrane potential, which is usually about minus 80 millivolts. Okay, but the whole concept of a refractory period, of refractoriness, is how we understand aberrant conduction. I mean, if you want to know about aberrant conduction, you have to understand refractory periods. So if you, let me just change my color. So understanding refractory periods means that if you try to stimulate this cell at this point in time, the cell is busy. It's depolarized and the cell won't respond. If you try to stimulate the cell at this point in time, still no good. If you try to stimulate the cell at this point where it's starting to repolarize, you're probably not going to get anything. But somewhere around here, when it's almost down to the resting membrane potential, and I sort of didn't draw this quite right because there is a time course. So when it's almost near the resting membrane potential, you might get a response out of the cell, and you might get another action potential. But the concept is that there's a certain period of time where the cell is refractory. That's known as the effective refractory period of the cell. But the thing is that the right bundle branch and the left bundle branch can have slightly different refractory periods. That's right. So different parts of the conduction system can have a different refractory period. So if you look at the right bundle, it might have a slightly longer refractory period than the left. That means if the AV node lets a beat down and it hits the bundle of His at a point where one of the bundles has recovered and the other hasn't, that's what causes aberrant conduction. Because then what happens is that the signal, it goes down one bundle, but it can't get down the other, and it blocks. And so now the signal has to go through the intramyocardial pathways to get to the other side of the heart. And that's what causes the QRS, instead of being narrow, to be wide or bizarre, or that's what aberrant conduction is all about, is when a signal comes in so soon that the conduction system in the ventricles is not willing to conduct it in an organized fashion, that part of the ventricle depolarizes late, and that's why the QRS gets wide. Okay, so number one, the first and foremost rule is that aberrant conduction generally is going to occur when the beat is premature. Okay, so let's go back to this. If we look at this first beat, is it premature? That's the first question you have to ask yourself. So if you look at the normal rhythm here, the normal sinus beat would have occurred around here someplace anyway. So to assume that the widening of the QRS complex is aberrant is sort of like your first mistake. The second mistake is that it's irregular. And a lot of telemetry techs have told me time and time again, absolutely, if you have an irregularly irregular rhythm that's wide, then it's AFib with aberrant conduction. I mean, it said that this is what they learned in school. This is what the textbook apparently told them. But that's just not a hard and fast rule. Granted, if AFib conducts aberrantly, it's going to be irregularly irregular, but not all irregular wide rhythms are AFib with aberrant conduction. All right, so let's look a little bit more closely at this first beat here. The QRS complex, for the most part, is sort of like looks markedly different from the underlying rhythm. So in this lead, the QRS is going up, and here it's going down, and here it's going up, there it's going down. So again, this one's up and this is down. So you have a very bizarre QRS morphology, and it's occurring late, so it's not likely to be aberrant. It's probably, at this point, going to be ventricular. And if the first beat is ventricular, then the whole run is ventricular. So that would make this ventricular tachycardia. Does that make sense? Okay, what are you trying to do is figure out where the first beat is coming from. Now, the question is whether you can see a P wave in front of the first beat. Because if you can see a P wave in front of the first beat, then that sort of suggests that it's atrial. And if we look in front of this first beat, there is a bump there. And that sort of confuses the picture, because I've always said, well, look for a P wave, and if there's a P wave in front of the first beat, then it's more likely to be atrial. Here's the problem. You have a lot of artifact, a lot of noise in this signal. I mean, the patient's probably rolling over in bed, and so it's hard to tell whether this signal is a real P wave or whether it's noise or not. I'm looking at Wyatt Adam, and he's got it right. The QRS complex occurs on time, so there's no reason for it to conduct with aberrancies, so it is VT. See, you guys are smart. You guys know what you're talking about. Okay. Now, Ricardo says there seem to be underlying normal P waves in lead 2. So, well, here's the thing. Since we don't know for sure if this is a P wave, and it very well may be artifact, now we have to rely on other means to diagnose this as VTAC. Right now it's looking like VTAC, but what would be like the absolute hallmark of ventricular tachycardia? What would clinch the diagnosis so that there would be no dispute? If you see AV dissociation, right? AV dissociation basically tells you that the P's and the QRS's are not connected to each other. And so let's take a look at the second part of this arrhythmia. So this went on for a few seconds, and it started out kind of fast, about 140 beats per minute, but notice it's starting to slow down. It's starting to slow down. And here, if you ignore my coffee stain, is the rest of it. And it's really becoming very, very slow. I mean, the rate over here is like less than 100 beats a minute. But if you look really carefully, I think you can see on this lead that there's a bump here that's not present there. There's another bump here, and those look to be like they may be dissociated P waves. Granted, okay, I admit there's still a little bit of noise there, but the fact that it's so slow and yet it's still very, very wide makes me think that it's a ventricular ectopic focus that just started to fire, and then because it's an ectopic focus, because it's an automatic focus, it's not re-entry, it's not going around and around in a circle. What happens often is those foci just basically start to slow down, and you get what's known as a cool down phenomenon. So this automatic ventricular tachycardia just sort of cooled down, and then it finally stopped, and then the sinus rhythm takes over again. Looking for AV dissociation sometimes involves sort of like comparing one T wave to another. And if you look at this T wave and you look at this one's a little bit taller. And I suspect there might be a P wave on top of it, which kind of you can see in lead 1, there's a little bit of a sharper deflection at that point in time. So I'd say this is VTAC. But the question is, what do you do with it? Clinically, here you have a woman who came in with an unrelated non-cardiac reason, and you have this run of ventricular tachycardia. What should you be most concerned about? Well, yeah, of course, you can have arrhythmias that occur because of electrolyte problems, let's just say. By the way, I hope that I've solved the picture audio sync problem. Actually upgraded to Wirecast 11, which I think they rewrote the software to deal with the video a little bit better, because I think I was streaming this 1080p video, and it was just sort of like causing the video to delay, but I did a couple of tests and it seemed to be better, so let's hope it's better. Anyway, what do you do with someone who has an asymptomatic run, long and ugly looking? Well, it's not that ugly because it's not that fast, but it's long and it's clearly ventricular. What do you do with that patient? Well, what happens in a teaching hospital is the nurse shows it to the doctor, and the doctor, well, let's check the electrolytes. Let's get magnesium levels, and let's do this and let's do that. Make sure they're not ischemic, order a nuclear stress test. A lot of times what happens is you might overreact. And I think some of it is, issues of liability and so forth. God forbid you don't want anything to happen to the lady. But in reality, automatic VT like this in someone with normal left ventricular function is generally just treated symptomatically. Now, this may have been the only run. It turned out this was the only run the woman had. She had no symptoms with it. Her left ventricular function is normal, and her electrolytes were normal. She wasn't on any diuretics. Everything was fine. So if this was a board exam question, and the choices were A, start IV lidocaine, B, start amiodarone, 400 milligrams TID, C, begin atenolol, 25 milligrams daily, or D, schedule cardiac cath, some crazy thing like that you can always cross that one out. But E, none of the above, would be really do nothing. And basically, if someone has asymptomatic ventricular tachycardia like this, in the setting of normal heart, normal left ventricular function, it does not really impact on their overall prognosis, and you don't have to necessarily treat this with medical therapy. You don't necessarily have to put people through extensive testing. Okay, so she's 68-year-old, let's say she's a smoker. Yes, darling, I'm a smoker. I've been smoking my whole life. So let's say that she has a family history of heart disease. Well, then in that case, she has multiple cardiac risk factors, and you might want to do some sort of objective test for ischemic heart disease. But most likely, whether she has ischemic heart disease or not, that would not be causing this. I mean, this is usually not a sign of acute ischemia, particularly in someone who has no symptoms. You're just like sitting there waiting for dinner to come along. So it's don't overreact. Look at the whole picture. Look at the whole patient, and keep in mind that when you have normal left ventricular function, automatic VT is often just a benign finding that you don't necessarily have to treat it. And now, if someone is having this again and again and again, and they're having palpitations, that's a different story. Then it would be appropriate to treat the patient just to make them, just to relieve their palpitations. So why is it not AIVR because of the start of the rhythm? See, AIVR is an electrocardiographic diagnosis, and it's basically based on rate. So, and this is again where you run into the problem when you rely on textbooks like Dubin's or like other textbooks. If you're looking at a textbook and they say, what's the definition of AIVR? It's a rate of less than 100 or less than 110, where it's arising from the ventricle and it's overtakes the sinus node, and you see AV dissociation, and then generally it stops. But this started much faster than that, didn't it? So in reality, what you have to think about is the physiology. What is causing this? And it's really this. Think of this in terms of the cells. There's a focus in the ventricle that starts firing rapidly, and then it begins to slow, and then it stops. Okay, so it's not really AIVR. It's not really VTAC. It starts as VTAC if you want to fit the definition, but then it slows down and becomes AIVR before it stops. That's why sometimes these electrocardiographic definitions just kind of confuse things, because the rate can change. And does that mean the arrhythmia changed? No, it's coming from the same spot. It's just the cells behave differently, and the cell behavior changes over time. So again, sort of like think in terms of physiology. What's causing it? Where is it coming from? And then you won't get sort of bogged down in terminology. You could call it AIVR, but strictly speaking, it's too fast to be AIVR. But the fact that it occurred late after the first QRS, I'll go back to that tracing here. So the fact that it occurred late after the sinus beat, yes, it behaves like AIVR, but the rate's a little fast. So what do you call it? You call it a run of automatic ventricular tachycardia with a cool down. It sort of becomes AIVR, but again, it's like just those kinds of definitions sort of just confuse people. Keep in mind, the term AIVR comes from an idioventricular rhythm. So if you just take a His-Purkinje fiber, let's say somebody has complete heart block, and they develop an escape rhythm from the His-Purkinje system. So it's going to be wide and bizarre, but it's going to occur at a rate around 30, 35, maybe 40. That's the rate where His-Purkinje fibers depolarize. By the way, ventricular myocardial fibers generally don't depolarize on their own. So even an idioventricular escape rhythm generally is coming from the Purkinje fiber somewhere, because myocardial fibers don't have much automaticity at all. The term accelerated idioventricular rhythm comes from the fact that, if an idioventricular rhythm is at 30 or 40 beats per minute, and this is at 70 or 80 beats per minute, it's accelerated. So it's sort of a weird, vague term that doesn't always help you when you're dealing with patients. So dealing with patients and dealing with electrocardiograms and dealing with real hearts, you have to just keep that physiology in mind and don't get too distracted by terms, and certainly don't get distracted by things that people write on the strip. So Jan says this is probably from the left posterior hemifascicle. So if it was coming from the left posterior hemifascicle, it would have a right bundle, left anterior hemiblock configuration. Because if it's arising from the left posterior fascicle, that left posterior hemifascicle is depolarizing rapidly. And then the signal has to travel up the posterior hemifascicle, get to the His bundle, then turn around and go down the other two bundles, the right bundle and the anterior hemiblock. So the right bundle and the left anterior hemifascicle are depolarizing later than the posterior hemifascicle, and that gives you the appearance of a bifascicular block with the right bundle, left posterior hemifascicle. If you look at this configuration, if this is lead 1, that top line there, it doesn't look like a right bundle branch block as much as it looks like a left bundle branch block. Here down in AVR, you have, it's sort of more left bundle-y looking. If it was a right bundle, it would be sharp and you'd have a big negative deflection, a broad S wave. So to me, this looks like it might be arising from the right ventricle or the right bundle branch. You have, it's negative in 2, 3, and F, so it would probably be the inferior portion of the right ventricle, and then traveling backwards up the right ventricle, get to the His bundle, and then go down the left bundle. So it would look like a left bundle branch block. Well, it's not terribly wide, so it might actually be arising from the very proximal portion of the right bundle branch. So if I had to guess, I would say that's where it's coming from. So I hope this was fun for you. It was fun for me. You know, these are completely unscripted, and I'm sort of just getting used to the idea of these live streams and trying to come up with something different and unique, but giving you a perspective on how an electrophysiologist thinks and how to approach ECGs in a more physiologic fashion. I think that's ultimately the best way to learn to read ECGs is from a physiologic standpoint and not relying on pattern recognition. So until you kind of get used to looking at things in this way, sometimes it's a little bit difficult to kind of switch gears, but you have to kind of get away from looking at something and say, well, that looks like this. So, you know, always question yourself, always think of what else could it be, and honestly, that's the best way to not miss anything. If you really enjoy this, thanks, Wyatt. I really appreciate the compliment, and you know, ECG Academy, that you can reach ECG Academy with a link in the description down below. I'm trying to get people to, again, think like I think. So it's not a basic ECG course by any means. I try to really get these advanced topics across to people so that they can use it in their career. And I really appreciate subscribers who take the time and support ECG Academy. Again, I have a lot of advanced topics online. I'm going to try to work on those as soon as I get my new recording studio up and running. And thanks for your support. If you want to learn more about ECGs, that would be the place to go. And if you have any future topics that you'd like me to discuss on these Saturday morning live streams, you can actually email me at drnick@ecgacademy.com. And until next time, let me see. Thank you very much for tuning in. And if you're watching this after the fact, thanks again for watching. And hopefully I'll see you next week.